Headaches is a very common presentation in primary and secondary care, and basically this is to help you define a clinical headaches. Basically, before we come to headaches, we must understand the pain sensitive structures in the head. If you were to stick a knife into the brain, it won't hurt, as the brain is not pain sensitive, but the extracranial areas such as the paranasal sinuses, the orbit, the ears, the teeth, the TM joints, the cranial nerves 5, 7, 9 and 10 carry pain impulses from these structures. Whereas the intracranial areas are the arteries in the circle of Willis, the dural vessels, the dural venous sinuses, and the veins, meninges, and the rest of the dura are pain sensitive. Now, headaches can be divided into primary or secondary. Primary headaches has no underlying structural or biochemical cause, whereas secondary headaches have an identifiable structural or biochemical cause, but all of it may not be sinister. 90% of headaches presenting to primary care are primary headaches, as compared to 60% of headaches coming to A&E. Generally, most sick people come to hospital, and so you would see a lot more secondary headaches presenting A&E. Now, the primary headache disorders can be further subdivided into those of short duration, which is less than 4 hours, in which you have mostly the TACs, which is the trigeminal autonomic cephalgias. Cephalgia is the word to describe headaches, which includes cluster headaches, paroxysmal hemicrania, and two fairly rare headaches which are very short lasting, called Sankt and Suna, and I'll explain these to you later. A longer duration of headaches greater than 4 hours is seen in migraines with or without auras, chronic tension type headaches, daily persistent headaches, and hemicrania continua. Now, secondary headaches, there's a vast variety of causes that have been described, which include vascular, including subarachnoid bleeds, intracerebral hemorrhages, stroke, infectious as in meningitis or sinusitis, post-herpetic neuralgias. It could be post-traumatic, elevated intracerebral pressure as in a mass or a pseudotumor. Decrease intracerebral pressure is spontaneous intracerebral hypotension, which is a condition where suddenly there's a drop of the intracerebral pressure. It's related to physical exertion. Someone may be doing some intensive physical work in the garden and suddenly will develop a headache, with classic low pressure headaches in which a patient feels more comfortable lying down, but the minute they sit up or stand up, cough or sneeze, the headache increases. Post-lumbar puncture headaches are also very similar. They're low-pressure headaches, and they can last up to a week after a lumbar puncture, particularly if several attempts have been made and the CSF continues to leak. Inflammatory, as in temporal arteritis, and this is a condition I've talked about earlier, and one has to be extremely aware and alert about this. Drug-related, especially patients on nitrates, caffeine withdrawal or sympathomimetics. Systemic and metabolic disorders include hyperglycemia, anemia, renal failure, or hypercarbia, and of course ophthalmic congestion such as glaucoma can also cause headache. Now, there are some red flags for secondary headaches. As mentioned, all of them are not sinister, but some of them you have to be aware, and they can point to something more serious going on. And therefore, if any headache presents with systemic signs and symptoms, fever, rash, a stiff neck, which can all indicate meningitis, but also if there's a history of weight loss and muscle pains, you have to think about giant cell arteritis. Systemic disease, any headache in the presence of immune compromised conditions such as AIDS indicates a serious underlying cause, or malignancy. Neurological symptoms or signs, if a patient is suddenly dips in his sensorium, becomes confused, impaired alertness or impaired consciousness. Focal signs or evident presence of papilledema indicates an underlying pathology. If there's a sudden thunderclap onset, these headaches are to be taken extremely seriously, as these could indicate a subarachnoid hemorrhage. Older patients and anyone presenting with a headache after the age of 50, we take it as it has probably a significant secondary cause still proven otherwise. And of course, if there's a change in pattern of headaches or triggered headaches by Valsalva, exertion, sexual intercourse, posture, all indicate that there is a secondary pathology which is significant and needs to be looked into. Now, there are some features that indicate a sinister pathology, so a thunderclap headache would always do so, or the first or the worst headache, new progressive headache, which the increase in frequency over a very short period of time, a new daily persistent headache, especially associated with abnormal features, fever, rash, or a focal deficit, change in headache frequency and character, and a patient who recurringly comes back to anyone has to be extremely alert that if someone is coming back again and again, there may be something is going on. Now, talking about thunderclap headaches, the most important thing to know is that we must know how quickly the headache has reached its maximum, and usually this is peaks in a minute and generally sometimes can abate as well fairly quickly. It's a high intensity headache. It's almost like someone's hit you on the head. There is a primary thunderclap headache as well, which does not have any underlying cause. On the other hand, it could be secondary to an aneurysm. Most of these patients present to the emergency room with a thunderclap headache, which could be potentially life-threatening, and only 1 in 10 will generally have a seborrheic hemorrhage. There are other causes for this as well. Some of them include arterial dissection, intracranial hemorrhage, cortical vein thrombosis, that's meningitis, and then of course there is a primary thunderclap headache as well. Spontaneous intracranial hypotension can also present with a thunderclap onset, where there's a sudden drop of the blood pressure in the brain. Now, chronic tension type headache is a headache that's fairly commonly seen in outpatients here. It's usually seen in ladies. It's mild to moderate. It's like a band-like pressure. They describe it as wearing a headband around their forehead. It can last from hours to days, and there's no focal neurological symptoms. Generally, these patients will present with a chronic headache more likely to, and essentially basically these chronic tension headaches, they seek help with a history of episodic headache, but delayed until frequency and disability are high, which makes them quite miserable, and then they to seek help for that. So essentially pain relief is offered, but we avoid an excess of analgesics or opioids, as these can lead to rebound headaches. Also they impair alertness and are not routinely used. Most importantly, these patients usually respond to amitriptyline, which is the drug of choice in these patients. Now, talking about migraines is a particular form of headaches which can be of various kinds. You could have an episodic migraine or a chronic migraine. Sometimes they can very rarely have a more frequent migraine, but by definition migraine is episodic. The episode can last from a few hours to a couple of days. It's accompanied by some auras in a few percentage of migraines. Most migraines are migraines without auras, and you can get migraines auras without a headache as well sometimes, especially retinal migraines, where they may present with some vision issues, but there would be no significant headache with these cases. Now, generally these criteria apply to all migraines, particularly those with headache. As mentioned, there are only a small percentage of migraine patients that have an aura. Most will have a headache lasting 4 to 72 hours. It's usually unilateral, but not invariably so. Pulsating in quality, moderate to severe in intensity, and it gets aggravated by routine activities such as climbing stairs. Most patients prefer to go to bed. There is nausea and vomiting quite frequently seen. Photophobia and phonophobia, where the slightest sound and light tends to disturb these patients. And this is the International Headache Society definition. The aura usually happens in younger patients. It can last from 5 minutes to about 60 minutes, usually between 20 and 30 minutes. It's a gradual progression of symptoms. It can involve taste, hearing, smell, but mostly you get visual auras where there could be dots, flashing lights, sparklers, spots in the vision, and the headache then tends to build up as the aura starts to fade. So how do we treat migraines? The first thing is to look for triggers. A detailed history is extremely important, in which we take a history from the patient. We try and find out what could possibly trigger it. Sometimes an excess of caffeine, a lack of sleep, a fair amount of stress, dehydration, but specific food items can trigger migraines, and various foods have been described. We do tell patients to avoid cheese, chocolate, red wine, particularly if once they start having frequent migraines, and it helps in a small percentage of patients. If there's infrequent attacks, we only give acute treatment, give them some pain relief and antiemetic, which generally settles them. But if they start getting frequent attacks, more than 5 headache days in a month, usually as per the BASH guidelines, which is the British Society for Study of Headache, then we offer some prophylactic treatment to prevent happening. Now, various prophylactics have been mentioned. So it can include first-line drugs, where we try the beta blockers. We try topiramate, which is an anti-epileptic but has an excellent migraine preventing effect, or amitriptyline if they're able to tolerate it. We generally try amitriptyline, or as it's a fairly safe drug, and usually 10 to 20 milligrams more than enough to settle patients, though the slide mentions up to 50 milligrams. If they don't settle with this, we usually give 6 to 8 weeks. We switch them over to another drug in the same group, and until one of them is helpful to the patient. The second line drugs, we can use venlafaxine, or we can use candesartan, which also has been proven to be effective in the prevention of migraines. And finally, we can use sodium valproate, or 𝒃𝒑, which we reserve for the extreme end. The sodium valproate is potentially teratogenic and has to be used in caution with younger women. It's recommended that treatment should persist for at least 2 to 3 months for maximum effective dose before considering ineffective, and before switching to another drug. And we do aim to withdraw this treatment in about 6 months' time to avoid excessive side effects of medication. Apart from prophylactic drug interventions, we can do things to help the patient. There's an occipital nerve block can be offered, which half the patients do show a response, but up to 20% show no benefit with this. Or we can use botulinum toxin, but they should have been offered 3 prophylactic medication at least, and if they fail these, then we can consider botulinum toxin, where they need to come in for an injection. Usually there are various sites around the circumference of the head where Botox is injected in tiny amounts. The mechanism by which it works is not entirely clear, but most patients have a quite significant relief with botulinum toxin. The only downside is that they need to come in for frequent revision of therapy, sometimes between 3 and 6 months time, but this gap tends to narrow as they develop tachyphylaxis. Certain gadgets have been developed to prevent headaches, as migraine is a spreading wave of depolarization, and sometimes by using these gadgets you tend to counteract that. You can use a gamma core device, a cephali, which is worn like a headband. A transcranial magnetic stimulation has been tried, occipital nerve stimulator, or a sphenopalatine ganglion stimulation. There's stringent criteria for the use of gadgets, and basically the first line would be to pharmacological means. Now, coming to the trigeminal autonomic cephalgias, if you remember, these are short-lasting headaches. The most common is cluster headache, which is more common in men. It's more common in smokers. It generally gets precipitated by alcohol, but this is an excruciating, most painful headache, which can be very troublesome to a patient. They pace about restlessly, unlike a migraine patient who tends to go to bed. You can have more than one attack in a day. Usually they last between half an hour to 4 hours at the maximum. Generally between 3 and 4 hours. But most cluster headaches episodes will terminate in about 2 hours time. They do terminate spontaneously, though certain abortive treatments have been recommended, and if they're instituted, they tend to abort an attack. It's a strictly unilateral frontal headaches centered around the eye. The eye can become bloodshot and droopy, and there is also watering from the eye and watering from the nose, especially the nostril on the affected side. Attacks can occur early in the morning, and generally most attacks are fairly infrequent. They do tend to come at the same time on the day, and that's why they're sometimes called alarm clock headaches, waking a patient up from their sleep. And now what you do when you've got a diagnosis of cluster, then generally there are various treatments that can be tried. Intranasal oxygen is or via mask is extremely helpful, and some patients who have frequent and chronic cluster headaches have been issued with the oxygen cylinder. Sometimes steroids have a benefit in the acute phase, and then they're rapidly tapered. Sumatriptan can be offered even by injection. One of the drugs that's been proven over the years to be most effective to prevent episodes is 𝑨𝒄𝒂𝒓𝒛. We have to do an ECG first, make sure the cardiac conduction is normal, and then we can use it. Some clinicians have tried lithium as well. Now, the trigeminal autonomic cephalgias are basically mediated through the trigeminal nerve pathway and its connections, and they have fairly straightforward characteristics which separate them from the run-of-the-mill migraines and chronic tension type headaches. The cluster headaches, as mentioned, can be up to 3 hours and vary in duration, but not more than that. They can happen more than once in a day. They produce a lot of restlessness, and alcohol is a trigger for them. Paroxysmal hemicrania is, as mentioned, one side of the head. It never exceeds more than 30 minutes. You can have up to 5 attacks in a day, and again the patient is quite restless. Alcohol can to some extent trigger these. SUNA is short-lasting unilateral neuralgiform headaches associated with cranial autonomic symptoms, and these can present with many attacks, up to 30, sometimes in an hour, lasting 5 seconds to 250 seconds at a time. Patients are restless, and these are not generally periodic. Now, what you do for cluster headaches, I've already explained to you, and the drugs are already outlined there. For paroxysmal hemicrania, they're exquisitely sensitive to indomethacin. In fact, sometimes it's a diagnostic test where you use indomethacin and see how the patient will respond to indomethacin, and if there's a dramatic response, it's likely to be paroxysmal hemicrania and not anything else. Generally for SUNA, if it's extremely troublesome, we do try some lamotrigine, as this is quite effective in terminating attacks. Now, I mentioned there's a strict criteria for neuromodulation, as they can be tried in attacks as well, that is the trigeminal autonomic cephalgias. Basically, you have to establish a diagnosis of primary headache syndrome. A patient should be very disabled by the headache, completely medically intractable, that all first-line treatments have been tried and failed, and thereafter we would give a trial with non-invasive neuromodulation. For migraines, you can try Cephali device, TMS or gamma core. For cluster headache, generally gamma core, and you can try peripheral neurostimulation as well with an occipital nerve stimulator. We've tried these phenylpalatine ganglions stimulator for cluster headaches, and if the patient does not respond to peripheral neurostimulation, sometimes patients have been taken up for DBS as well, but the selection criteria for this is very strict. Just a couple of words about postcoital headaches, as these can present with a thunderclap onset, and it's not unknown for an aneurysm to rupture during coitus, particularly at the extreme of sexual activity. It's basically a pressor response to exercise, which suggests as a migraine. The headaches have an immediate onset, and or sometimes they can worsen during sexual intercourse, and some of them are fairly explosive, occurring at the time of orgasm. Now, these patients are generally investigated. If they present acutely, they're admitted, and they may go through the full workup as a case of subarachnoid hemorrhage with a CT scan and a lumbar puncture. Patients are advised thereafter to abstain for a while in between medications such as beta blockers, is tried, or indomethacin, and generally the advice is to try and take this slightly before the coitus to prevent the recurrence of headache. Weight loss is recommended, and increased exercise, and at times clinicians, if they have a high index of suspicion, may do a CT or a CT angio or an MR or MR angio to exclude any intracranial bleeding or vascular malformations such as an aneurysm. Thank you very much.